Hi, my name is Kevin Stein, and I'm the Managing Director of the American Cancer Society's Behavioral Research Center. It is my honor today to introduce Dr. Jim Zabora, who's the Director of the Life with Cancer organization for Inova Health Systems and the former Dean of the School of Social Services for Catholic University in Washington, D.C. Dr. Zabora has a long history of conducting research aimed at helping oncology professionals to assess and address the physical and emotional problems that cancer patients and their loved ones face as they battle their disease and its treatments. He was a pioneer of screening for emotional distress and for helping to develop some of the early tools used to identify patients at risk for anxiety, depression, and other psychosocial issues that may result from cancer and which may negatively impact their quality of life. Here at the American Cancer Society, we also strive to conduct high-quality, high-impact behavioral and psychosocial research that may help cancer patients, survivors, and their loved ones cope effectively with the challenges associated with the diagnosis, treatment, and survival of cancer. To help achieve this goal, in 1995, the ACS established the Behavioral Research Center, or BRC for short, as one of the programs within the Intramural Research Department. The BRC was an early leader in cancer survivorship research and led the development of the American Cancer Society's Studies of Cancer Survivors, a program of research that included both cross-sectional and longitudinal components. In these studies, we've assessed more than 15,000 cancer survivors and have followed thousands of them as they progress through the cancer survivorship journey. We also included several thousand cancer caregivers in these studies, allowing us to assess the unique needs of those who care for their loved ones with cancer. More recent efforts of the BRC include the development of a system for assessing and monitoring the physical and emotional symptoms experienced by patients undergoing active treatment, as well as a study focused on the unique needs of cancer patients as they transition off of active treatment and return to their former roles under the care of the community primary care providers. We also conduct research to understand and address factors that impact individuals' ability to successfully quit smoking, as well as research to identify the sociological and environmental contextual factors that lead to and perpetuate disparities in cancer incidence and mortality. Much of this work was made possible by early pioneers in the field of psychosocial oncology. Dr. Zabora is clearly one of these individuals. He has published more than 50 articles in peer-reviewed journals, authored more than 20 book chapters, and presented over 300 invited lectures and presentations. In sum, he has been a leader in the field of oncology social work for more than 30 years and has continued this work to this day. In recognition of Dr. Zabora's lifetime commitment to cancer research, he was recently honored as the recipient of the 2013 ACS Quality of Life Award. Jim is also a proud native of Baltimore, Maryland, and if you let him, he will be more than happy to tell you about his hometown and its many accomplishments. We are fortunate to have Dr. Zabora here today to present a talk he gave at the AOSW annual conference in San Diego entitled, "What Does Excellence in Oncology Social Work Look Like and How Can We Achieve It?" Please join me in welcoming Dr. Jim Zabora.
Thank you, Kevin. Absolutely delighted to be here. I first of all would like to thank the American Cancer Society for sponsoring, I think, this important award related to quality of life and cancer care, and also for the Association of Oncology Social Work, because I know they certainly supported my nomination. This talk has evolved over the last several years. It's my way of kind of thinking about oncology social work and how can we really move towards excellence in care. If you're interested in having these slides, I'll send you the complete set. All you need to do is send me an email, and I'll just attach the slides and send them back to you. Yeah, I always like to start with Gary Larson, and this cartoon, as you can see, it's a convention related to dinosaurs, and they're talking, and basically they're saying the climates are changing, the mammals are dying all around us, and we're really challenged, and all of us here in this room only have a brain the size of a walnut. And now, the reason I wanted to show this to you is simply because our brains are far more capable than dinosaurs. And if we could come together as an organized group of people in terms of looking at what is excellence in care, I think we can achieve a great deal. This quote is from Albert Owens. Albert Owens was the founding director of the Cancer Center at Johns Hopkins. And he was my first boss there in 1983. I had been on the job for about 2 weeks. And he called me to his office and he said he wanted a strategic plan. And he'd like to have it in about 7 days' time. I respectfully requested an extension on that deadline. And he said, you'll have it to me in 7 days. so my request was denied. And what I put together was from a social work perspective at that time, and it was a lot of volume data, a lot of demographics, a lot of problems, problem codes in terms of what our patients and families were experiencing, and about 7 pages of that type of data. And Dr. Owens looked at me and said, "Jim, please go to page 8. And I said, "But Dr. Owens, I really want to tell you and share this data with you." And he said, "Please go to page 8. And I said, "Please, let me do this and show this data to you." And he finally said to me, "I really don't care how many pillows you fluff." And what he meant by that, and it was a very important statement for me, is he said, "I don't care how many patients you take care of. I don't care if it's 900 or 1,000 or 1,200. I want to know what happens when an oncology social worker walks in a room, sits down with a cancer patient. How does the patient benefit from that?" So I really liked my job at Hopkins. I'd only been there for 2 weeks, so I thought I'd better begin to think about data in a much different way. This particular slide gets at the issue of social workers and research. And this is something I've thought about. And what I wrote about 2 years ago was, without publishing results, science would be dead. And my thinking about that was that science not only has to be completed, but it has to be disseminated. People have to see it, and they have to use it. So without publishing and the use of scientific principles to measure outcomes, I have worried for some time that the field of psychosocial oncology might someday die or go out of existence. And if you look at this particular quote from Williams and Hobbs, this was published in 1987, what seems to set social work apart from other professions is social workers' well-documented aversion to research. And as dean in a school of social work, graduate students would frequently come to me and say something to the effect of, "Why do we have to take 3 research courses?" And my response was, "Because it's extremely important. I think those 3 courses are just as important as any of the clinical courses that you're taking, because you have to be able to conceptualize what you do on a day-to-day basis and how fundamentally you make a difference." So as I began to think about the word excellence and how this could be applied to oncology social work, I came across this quote that I could not locate the author's name for it, but excellence can be attained if you care more than others think is wise, risk more than others think is safe, dream more than others think is practical, and expect more than others think is possible. So excellence is something to really be striven for and achieved. And if you want to take a look maybe at a philosopher such as Aristotle, excellence is an art won by training and habituation. We do not act rightly because we have virtue or excellence, but rather because we act rightly. What we are, we repeatedly do. So excellence is not an act, but it's a habit. So we should always be having this word excellence in the front of our minds. Some other quotes: excellence is not a skill, it's an attitude. We should always think about excellence as we're creating programs and thinking about outcomes. Excellence is doing ordinary things extraordinarily well. So you could just think, for example, in a support group, it may be for 8 patients, lung cancer patients, say, for example, but you could do that group extraordinarily well. And then the noblest search is the search for excellence, a quote from Lyndon Baines Johnson. So as I began to think about excellence, I then began to think about leadership, because there has to be a strong relationship between excellence and leadership. So John Quincy Adams told us, if your actions inspire others to dream, learn more, do more, then you are an effective leader. Or Eleanor Roosevelt said it very simply: you must do the thing that you think you cannot do. So we really need to challenge ourselves. So if you think about excellence and then begin to think about leadership, it all relates to visioning. So what future state do we really wish to create? At Life with Cancer, we developed a strategic plan back in the end of 2012. And we really set a vision for ourselves, is that we would strive to be the leading psychosocial program in the country. Our unique mission is providing care to cancer patients and their families, regardless of where they receive their treatment. Our strategic objectives: we're working on making sure that all of our programs are evidence-based. working on development to make sure that we're financially secure, developing a research program and a data management system, and then our reputation, not only within the Inova health system, but throughout the state of Virginia, the region, and also on a national level. So if you're following this kind of train of thought, this leads to thoughts about effectiveness for oncology social workers. So these are just simple definitions that I got out of the Webster's Dictionary. So effectiveness means to be successful, useful, helpful, valuable, efficient. And I just kind of got on a roll and began to think about other terms such as accomplished, competent, real, capable, adept, knowledgeable, and so on. So I think these are the traits that oncology social workers should really strive for, and to achieve that, they can demonstrate their effectiveness. Now, as we begin to think about measurable outcomes for oncology social workers, I think these are some of the most important 6 that are out there. Obviously, we would hope that our interventions and our programs would decrease the stress, improve quality of life, and I think if we do that, we would increase the overall patient satisfaction with cancer care in general. I think we need to think about how do we enhance symptom management and how patients talk about their symptoms and the severity of those symptoms. We need to think about family functioning. Sometimes when we talk about families, we think about that there's one generic family out there, but in reality, there's significant variation in day-to-day family functioning. And if we can begin to do these things, I'll show you a model at the end of this talk, how I actually think we can impact on healthcare cost or healthcare utilization. So all of this involves taking a risk. So then we go back to Larson to guide us in risk-taking. And as you can see, someone's been wounded quite severely working on the walls of this castle. So then I says to Borg, you know, as long as we're under siege, one of us ought to moon those Saxon dogs. Now, why would I show you? This is about risk-taking. And I really think oncology social workers, in order to achieve excellence and to prove they're effective, from time to time is going to involve taking a risk. But I think you need to minimize those risks and maybe not to go to this degree of taking a risk. So a word about management. This quote is from Alvin Toffler's Power Shift, which is the final book that he wrote in his trilogy. And I just want you to focus on the first sentence. Fear is the primary idea assassin. And I really think that social workers across the United States from time to time get paralyzed by fear about putting their ideas out, about writing abstracts for presentation at national meetings, about trying to do a piece of research or trying to write a manuscript. But we really need to move forward and to be able to take these risks and put the fear aside. Because as the last sentence in this slide says, innovation in contrast requires experimental failure in order to achieve success. So we need to think about those words. So one thing that I've done is, this was published in the Social Work Desk Reference in 2009, and I tried to conceptualize how social work departments are constructed throughout the United States. And I think a good number, probably the majority of hospital social work departments would follow this very traditional model, where they have a highly focused mission, primarily discharge planning emphasis. Their budgets are, for the most part, very restricted. They're concerned, like that data that I mentioned earlier in 1983, about volume-driven data and very limited evaluation in what they do. A more progressive model would be for departments to begin to try to expand their mission, find other ways of managing the discharge planning issue, really create a more clinical emphasis, develop new social work activities and programs, develop new revenue sources, and really begin to evaluate their services in a systematic way. And then finally, and this was I think would describe the department we had at Johns Hopkins from 1983 to 2002, a highly innovative department which really has a diversified mission and services. It's clinical, it's education, also has a research emphasis. That clinical interventions are done prospectively, and that's when we began to screen for distress in the 80s. To have multiple revenue sources. At that point in time, I had 7 different revenue streams, and really to evaluate all of those programs in terms of their effectiveness. This raises the question of evidence-based practice. And this is a real challenge, I think, for social workers and somewhat, at times, intimidating. But evidence-based practice, as you can see, possesses the ability to prevent numerous avoidable deaths and injuries and improve the quality of life for millions of people. Now, I think all of us would agree that we know our programs can improve the quality of life for millions of people, but often oncology social workers do not think about primary or secondary prevention where they could actually get involved in trying to prevent avoidable deaths. I'm going to show you two slides from some activities that took place at Hopkins towards the latter part, right around 2000, 2001. This is data from Baltimore City related to the 4 major cancer sites and their mortality rates for Baltimore City. And as you can see, there are significant disparities between African Americans and the rest of the population. And the most glaring disparity here, if you look at prostate cancer, the death rate among African Americans is 3 times higher than any other population within the city of Baltimore. So as a group of social workers, we looked at this data and we tried to begin to conceptualize how could we bring about some fundamental changes. But it was important for us to look at this data, to be able to see it. So what we did is we geocoded it and mapped it. And as you look at this map of the city of Baltimore, you begin to see various census tracts that are color-coded. And the darker they move towards red, the higher the mortality rate. So this allowed us to take money from the Baltimore Cigarette Restitution Fund that was given to us by the state of Maryland and develop a prostate cancer screening program specifically for African American men. Now, most people in the city of Baltimore, as well as the state of Maryland, felt that we were going to fail miserably and only wanted us to set the screening rate for the first year very low, maybe 250 men or 500. We decided to set the target at 1,000 men our first year and actually screened 1,050 men through this program. Now, if we could sustain that over several years, the first year out of this 1,050 men, there were 4 men diagnosed with prostate cancer, all stage 2. 2 were uninsured, 2 did have insurance. They were all treated at Hopkins, and they were still receiving follow-up care at Hopkins when I left in 2002. But if we could sustain that over a period of time, say 5 to 7 years, we probably could have actually showed a decrease, a significant decrease in the mortality rate. So as we move away from primary and secondary prevention, we begin to talk about tertiary prevention, which is minimizing the effects of the disease once a cancer diagnosis has been made. I came across this paper when it was published in 1998, and this paper really stimulated us to move towards distress screening, because what Rainey and the group at UCLA said that the reasons you refer someone for psychosocial care is severe anxiety, depression, delirium, suicide, or conflicts between patient, family, patient, staff, and so on. And as we just simply looked at these bullet points, we began to say, we would like to intervene at an earlier point in time. So if we could go back and look at the literature and look at the early work of Wiseman, Warden, and Sobel at Harvard and Massachusetts General in terms of distress screening, perhaps we could find these patients at a much earlier point in time. This paper was published about 10 years later, but it really re-emphasized for us what we need to do as oncology social workers. Because as you can see from the slide, when oncologists were actually tested on their ability to identify the clinically anxious or clinically depressed, they were only correct 17% and 6% of the time. And when they had more time to spend with patients, their accuracy rate actually improved, but it still was not significantly high. So as we moved forward in the 80s, we began to think about all of this from a theoretical perspective as well. And we adapted Lazarus and Folkman's stress model theory to not only explain what's happening to patients on a day-to-day basis as they move through the cancer trajectory, but we also wanted to use this for research as well. So if you look on the left-hand side of the box, you see a stressor is introduced into a person's life. And for purposes of today, obviously, that stressor is the diagnosis of cancer. And before an individual can really move and take action, as you can see on the right-hand side of the box, to really begin to manage their illness, they really have to develop a definition as to what this cancer means to them. So we know from our research that about 70% of the time, patients will tell us that they certainly don't want cancer, that it's a major disruption in their lives, but it's a challenge and they feel that they can overcome it. Where we know from the remaining 30% is that meaning is much more negative, and they tell us that probably no matter what they do, they're not going to survive. Now, the box in the middle, the yellow box, is really influenced by how many resources they have available to them, both internal and external. And I've given you just some examples. So, for example, on the internal resource side, their personality, their sense of mastery, are they more optimistic than pessimistic? We did the first study looking at spirituality as it relates to stress at Hopkins in the late 90s, and we were able to show we could not only measure spirituality, but also that the higher the spirituality, the lower the stress in the patient. And then most recently, a good deal of work in problem-solving education. So problem-solving is a skill, and we know, again, from our data that about 30% of patients just have poor problem-solving skills. And this is something that we can really, really strengthen. And on the external side, family, friends, employer organizations. So the number of resources that any given cancer patient has will vary pretty significantly. The more resources they have, the more likely it's going to be a positive meaning and that they can move forward and take positive action and manage their illness. One quick word about families, and this gets back to what I said earlier about there's not one generic family. And this is the work of David Olson from the University of Minnesota and his circumplex model of family functioning. And what Dr. Olson did was he really looked at all the family literature over the past 30 years prior to publishing this book, Families, What Makes Them Work. And he reduced the critical constructs about families to 3. Number 1, adaptability, their ability to reassign roles under significant stress, cohesion, the degree of emotional bonding between family members. And what I really like about this model is he conceptualized the family life cycle. Often we talk about patients as being a pediatric patient, an adolescent, a young adult, an older adult, but we don't think about the fact that the family is going through a developmental life cycle as well. And he talks about 7 distinct stages based on the age of the oldest child, because as that child ages over time, those developments create major challenges for the family as a whole. This gets at distress screening. And another Larskin cartoon, obviously. And so basically the physician is saying, well, Mr. Crumbly, maybe it isn't kidney stones after all. And as you can see, the horn of the rhinoceros is in a very uncomfortable place in Mr. Crumbly's back. Well, Mr. Crumbly came into the radiation oncology department at Hopkins, and in essence, he had scored the highest on our screening instrument that we had ever seen. And he checked off that he was thinking about suicide all of the time. And as we sat down with Mr. Crumbly to really kind of take a look at his life, his distress was the size of a rhinoceros. And when we were finished, I asked the social worker to go back through radiation oncology, talk to staff, and find out if they noticed anything unusual about Mr. Crumbly. The entire staff said that he seemed to be coping very well. Had we not asked those critical questions at that point in time, I would have had real concerns about what would have happened to Mr. Crumbly. So why distress? Why did we pick this as a concept that we really wanted to focus on in the 80s? And the reason being is I think we have biomarkers for disease. I think distress is a marker for everything that oncology social workers should be interested in. And the studies have been done to show the relationship between these 6 bullet points. So the higher the sense of mastery, the lower the distress. The higher the spirituality, the lower the distress. The higher the social support, the lower the distress, and so on, including the higher the problem-solving skills, the lower the distress. So I know most of you are familiar with the NCCN guidelines that have been updated repeatedly, and it's important just to consider this definition that distress is an unpleasant emotional experience, psychological, social, spiritual. that interferes with the ability to cope effectively with cancer. And the only thing I would change about this definition would be to eliminate or delete the word cope. Because cope for me is just too ambiguous, and I think we need something in there that's much more specific. So what I would do if I could would be to replace the word cope with problem solve. Because I really think this is a fundamental skill that we have to be sure that cancer patients have so that they can really manage all aspects of their disease. The other important thing about distress is that it does fall along a continuum. And there are low distress patients, there are moderately distressed patients, and there are high distress patients. And while I've always been concerned about the high distress group, most often patients, wherever they are with their distress, probably would benefit from some level of services. The question for me is what services would benefit a low distress patient versus a moderate versus a high distress. So another word that we use quite frequently is the word adaptation. And I came home one night and I brought home 7 or 8 social psychology textbooks because I wanted to find a definition that I felt comfortable with for adaptation, something very simple but very, I guess, encompassing. And I was sitting in my wingback chair and I was kind of throwing the books on the floor. I was frustrated. I couldn't find a definition. And my wife happened to be sitting on the sofa across the room grading papers for her 4th grade science class. And she said, "What's the problem?" I explained it to her. And she said, she gave me her 4th grade textbook. And she said, "Try this for adaptation. And a special trait that helps an organism survive." That to me did it. Because I think we have to look at each individual and find those traits that are going to help them survive through this whole illness. So as we began to screen at Hopkins in the 80s and moving on through the 90s, we amassed a database of about 25,000 patients. And for this particular study, we extracted 4,496 cases because what we wanted to look at is the prevalence of distress by cancer site. The specific cancer diagnosis. So as you can see, there's significant variation from diagnosis to diagnosis, but lung cancer patients, it's significantly higher than, say, colon or breast. Because at that point in time, although CT scanning is now coming in as possible, for screening for early lung cancers, at that point in time, that study was just starting. And so 36% of all lung cancer patients are significantly distressed, and that's 2 standard deviations above the rest of the group, followed by pancreatic and so on. And these are diagnoses that we really do not have effective treatments, and often these patients are found late stage, versus breast and colon, where we do have the ability to do early detection and offer effective strategies. So screening for us, and this comes from Wiseman, Ward, and Sobel, it attempts to identify patients at the greatest risk for future distress and to intervene with especially the vulnerable patients. And while we need to do that, as I said before, we need to focus on the moderate and low distress patients as well, because there are programs that they would benefit from. So this was our first screening study that we published in 1990. And what we did with this, we took the early work of Wiseman, Ward, and Sobel. They were called the Omega instruments. And in essence, it was a structured interview, 20 to 22 questions, followed by the inventory of current concerns, which was a 72-item kind of inventory. And you actually came up with a score, and if it was 7 or higher, that indicated the patient was high distress and that they should receive immediate assessment and intervention. For me, at that time, I felt, 25, 30 minutes still was, we could do better in terms of screening. So we compared the Omega instruments, because they were considered to be the gold standard, to the brief symptom inventory, which was 53 items. And what we were able to show is that the BSI, that took 5 to 7 minutes of patient time and 2 or 3 minutes of staff time, that we could identify the patient in a much more efficient way. And then the cost-benefit considerations at the end, at that time I actually calculated if my staff would do a clinical assessment on 4,000 patients that would coming through the doors at Hopkins. What I determined was they'd be assessing someone every on the hour, 5 days a week, 52 weeks a year, and that would cost well over $100,000, where we could screen them for only $12,000. We still were not satisfied with that, and we engaged with Pearson Assessments. They have the copyright to the Brief Symptom Inventory 18 items from the larger BSI. And we did a follow-up study with over 1,500 patients to show that the BSI 18 was just as effective as the BSI. A little bit less in terms of reliability, but still very, very acceptable. And we gender normed it, because what we learned from that particular study that men tend to underreport their psychological symptoms. And with the BSI 18, we could screen someone in about a minute of time, and it was an additive scoring mechanism, so staff could just add it up and have an instantaneous result in no more than about a minute. This is just for you to be able to see the items on the BSI 18, and this was always paired because the NCCN guidelines recommend that there also be a common problem checklist. And we were the first ones at that time to add pain and fatigue as Likert scales. This was right around the time when the Joint Commission on Accreditation of Hospitals came out with a mandate that patients also need to be screened for pain. So we took that item under the Department of Oncology Social Work so that we could comply with JCHO. This is the newest scale that we're working on. It's called the Chronic Illness Distress Scale, short form. It's only 7 items. We think a patient can complete this in probably 30 to 45 seconds. And again, it'll be an additive scoring mechanism. The IRB at Inova has approved this, and we're in the process of hiring a research assistant. So this instrument, we're hoping we can finish the reliability validity testing by the end of the calendar year. And just to say a couple words about problems, this is a study we published over 1,100 patients about some of the most common problems that cancer patients, and you probably have seen a number of these types of studies. Fatigue and pain are always the most common problems until Matt Lascalzo several years ago at the City of Hope asked about sleep. He actually was the first one that put sleep on his screening questionnaires, and what he found out was sleep is the second most common problem. About 60% of all the patients that he has screened indicate sleep is a major problem. So back to evidence-based practice. It places the emphasis on the use of scientifically validated assessment, intervention, and evaluation procedures. Most often when people talk about evidence-based practice, they only think about the outcomes. But if we're going to engage in distress screening, the instrument should be valid and reliable. And certainly there are questionnaires out there that people are using that are not as reliable and valid as we would like to see them. But also the psychosocial assessment should also be based on the literature. I've done a couple of talks in Virginia for oncology social workers in Richmond and Charlottesville, and I asked them the simple question, how do you decide what is in your psychosocial assessment? And virtually what all of them have told me is my supervisor taught me how to do this, or my field instructor when I was in the School of Social Work taught me how to do an assessment and what questions they ask. So I asked him, well, how many of you ask about spirituality? And no one raised their hand. And I said, well, about 95% of people in the United States believe in some kind of a God or have a very strong spiritual beliefs, and you're not asking about that. And I said, well, how many of you ask about sexuality or intimacy? No one raised their hand. And I said, well, about 70% of all cancer patients have serious concerns about sexuality and intimacy as they go through treatment. And I said, how many of you ask about problem solving? And once again, so none of these items where I think if you look at the literature would say these are the kinds of questions we need to be asking. So early experiments in transportation, back to Larson. I really don't think this is the way we want to approach our interventions in any kind of an experimental way. And if you really look at the literature, probably one of the best papers on psychosocial interventions was published by Fauzi and a group out at UCLA in the mid-90s. And what Fauzi did was looked at approximately 250 intervention studies. And he basically concluded at the end of that paper that in terms of psychosocial interventions, it's not as though we have 100 interventions that we can offer. He basically said there are 4, and that we can provide education. Many people are now calling that psychoeducation. We can provide a cognitive behavioral intervention, and there, most often people would agree there are about 17 cognitive behavioral interventions. Group interventions, and he said, you know, the traditional support group where people come to share or ventilate really don't benefit patients, that when the group is more structured towards disease management, patients do significantly better. And short-term psychotherapy. Both Matt Lascalzo and I believe that problem solving could be a 5th intervention, because for us it's a blend of psychoeducation as well as some cognitive behavioral techniques. So if you look at Fauci's paper, I mean, there's significant evidence in the one paper. There are 4 randomized trials discussed related to psychoeducation, 7 randomized trials related to cognitive behavioral, and so on. And in terms of problem solving, at the point at which I made this slide, that literature was just developing, and there were 2 major randomized trials that showed a significant benefit to the problem solving intervention. So if you begin to bring this together, and this is a slide that we developed at Life with Cancer some time ago, we went through the 60 programs and services that we offer at Life with Cancer, and we, in a sense, categorized them. Is it psychoeducation? Is it cognitive behavioral, disease management group, or brief counseling, short-term psychotherapy? And then we spent a great deal of time as a staff saying, given this intervention, what would be the anticipated results? So for psychoeducation, we would hope to increase people's knowledge, reduce a sense of helplessness, cognitive behavioral, reduce anxiety, maybe other symptoms, and so on. And then we made a list of outcomes that if we were going to measure outcomes in a systematic way to show the impact of the interventions and did we achieve these results, then we concluded that our program should reduce distress, reduce the severity of symptoms as perceived by the patient, and improve quality of life. And then I'll share with you at the end some thoughts about healthcare utilization or healthcare cost. So Matt Lascalzo came into my office one day at Hopkins and said, I need some help. I want to come up with a definition of a problem, and I need about 2 hours of your time. And if you know Matt and I told Matt I didn't have 2 hours of time to go back to his office and come up with a definition. And he came back about 2 hours later, and I think this is an outstanding definition, that a problem is a demanding life event for which an adaptive response is not immediately available. So if you think about that, it becomes pretty clear that a number of cancer patients are going to have significant problems that are going to be demanding their attention, and they just don't know how to manage it. So here are some of the, just an outline for you to consider in terms of what is problem solving. And it's a set of very specific skills, but it starts off with problem orientation, really trying to do a motivational piece with an individual cancer patient to really think about the fact we're going to work on these problems together, that they're going to learn a new skill, and really try to frame this in a very positive way. The next 4 are the skills that you actually teach in terms of what is the problem and coming up with a clear definition. The example I use most often is a patient, the problem cannot be depression. If that's what the patient is saying, then we really have to work with the individual to try to begin to conceptualize exactly what is causing that depression, because then that will become the problem. The example I frequently use, we had a late-stage lung cancer patient who was going through this, and that's all he could say for about 30 minutes is how depressed he was. And finally, he began to change his thoughts and said, you know, I know that I only have about 3 months to live, and there's a family reunion coming up in a month's time, and I just dwell on it, and I know I'm not going to be able to get there because, you know, I'm feeling worse every day. And we spent some time talking about that, and his wife immediately chimed in and said, you know, we're going to work on this together, and I'm going to get you to that reunion. And she was able to do that. They developed a very effective plan based on the fact of how important that was for him. And he was able to attend. He was able to see all of his relatives, make his final goodbye, and then died about 2 weeks later in a much different frame of mind. Brainstorming is something that can be very difficult for some patients. because their thoughts are in a sense locked in a box, you know, in their brain, and they just can't come up with an idea as to maybe how to solve a particular problem. And when patients, in a sense, get stuck with that, normally I'll give them an unusual object, like my ID badge or a chopstick. And I'll say, gee, this is a chopstick. I use it to eat Chinese food. What would you use it for? And you can't say it's a chopstick. Now, most often patients will look at me and be very, very puzzled. But as they begin to look at that chopstick, they begin to say, well, I have a plant at home. I could use it to hold up my plant. I have a broken window. I could hold the window open. I could use it to scratch my back. And what you've done, in effect, is just a cognitive intervention to enable them to think about a chopstick in many different ways. Then you can take them back to the problem that they've identified, and they're ready to begin to look at alternatives. You then do a systematic cost-benefit analysis, looking at each item that they've come up with, and what are they really willing to try to do today, then carrying out the plan and making sure that the problem has been solved. This was our first study that we did at Hopkins. It was funded by Project Death in America. They were looking for novel interventions at end of life. It was a small grant. It was $60,000. So we wanted to see what would happen with one 90-minute session for someone that was at end of life and a family caregiver. And pretty amazing results for one 90-minute intervention. Only 6% said they did not feel confident to provide care, and this was coming from the family caregivers. 83% stated the home care guide made a significant difference, and the home care guide was a manual that was developed, 22 of the most common problems that cancer patients and families have outside the hospital. We were able to measure problem-solving skills. There was a very effective measure, and showed that 65%, or 2/3, really improved their problem-solving skills. And problem-solving scores were significantly higher at the post-education point. What that told us, though, when we went back to look at the 1/3 that we were not able to really improve their problem-solving skills, we found that the key variable was family functioning. Whether or not they were a balanced family or a more extreme family that were really struggling on a day-to-day basis in terms of family functioning. So we were able to get an RO3 from the National Cancer Institute, and what we did is one session, again, trying to replicate our results from the first study, one session for balanced families and 3 sessions. So in effect, what we did here was increase the dosage of the intervention given more extreme families 3 sessions, and we saw a benefit. Those extreme families experienced an increase in problem-solving skills and a modest decrease in distress after only 3 sessions. However, we lost that effect at 6 months. And this has been giving us some thoughts about the idea of dosing and the interventions that we use, and maybe perhaps some point in time actually doing behavioral studies that are dose escalation, trying to find what the right dose of an intervention is to get the maximum benefit. So some other pilot studies that we did, this was part of our core grant. It was a pilot study with 12 African-American cancer patients where the primary issue was depression, and we put together a 4-session problem-solving program. Depression scores decreased by 2.5 and on the BSI-18, and the quality of life scores increased by nearly 6 points at 30 days post-intervention. The feedback that we got from these particular patients that they felt there was a much lower level of stigma, that it normalized their cancer to them. So there was a very positive response to the educational format, and they felt a greater confidence to manage their problems. Can you spare me a few words to minimize my problems? This is one of Matt Lascause's cartoons, because we also were able to form a relationship with Men Against Breast Cancer, which was a national organization back when we were at Hopkins, and we actually developed the first National Male Caregiver Conference. It was sponsored by AstraZeneca, and we brought 50 men from across the United States to go through 6 hours of training and problem solving so that they could become better and more supportive partners to their spouses or partners with breast cancer. And we found some pretty amazing results from this first male caregiver conference. Number one, people told us 50 men are not going to come to Baltimore to help one another, share their concerns, and problem solve together, but they did. We have it on film, so I can show you 50 men in a room actually helping one another. But what they said in terms of their evaluation, that we achieved our learning objectives, all these are on a 5-point scale, that it was relevant, it was practical, they felt they'd be better caregivers, they were more confident, and that the overall quality of the program was 4.8. And 100% said they would recommend this particular program to other men. So we brought all this together now at Life with Cancer. When one will start screening with the 7-item instrument, it'll be part of the EPIC, the electronic record, so we'll be able to comfortably say we're screening all patients diagnosed with cancer throughout the Inova health system. High distress will go into Life with Cancer, and then target it with specific programs. They'll go through a registration process at that point in time. That's when they'll complete the symptom measure and the quality of life measure. And then all this will be loaded into an outcomes database so that we can go back over time, repeat those measures, look at all these individual programs, look at individual therapist or counselor or nurse performances, and really make some judgments about how we can really even further enhance our programs. Now, this is a study that was published at the Mayo Clinic in 1995, and this gets at the issue of healthcare utilization. And the instrument that they used in this particular study was a symptom checklist 90, which is the grandparent of the BSI 18, and so on. And they just dichotomized patients, high distress, low distress, made that cut point. And high distress patients actually were 15 times more likely to be rehospitalized. High distress patients were almost 13 times more likely to have a second cardiac event. And when they were rehospitalized, they actually cost $7,000 more. And what this taught us was that there's something happening with the stress, how people present with symptoms. You begin to think about studies, the higher the depression, the higher the pain scores. And we actually think that this plays itself out, the way patients come in and talk about certain symptoms. When I presented this at Hopkins, somewhere around 2001, I was talking to the IRB within the Cancer Center, and the director of the lymphoma program was laughing all the way through my presentation. And at the end of the presentation, I said, with all due respect, Dr. Flynn, what is so funny about what I'm saying? And he says, I think you're right. He said, I think lymphoma patients are the most anxious patients I've ever met. And every time they come in for follow-up, they want another CAT scan to make sure that they're okay. And I said, well, what do you do? He said, I normally get in. I give in, and I normally do a 700-hour CAT scan, and I usually don't find anything. So we'd like to see this kind of play itself out. So the framework for this economic model, there are certain assumptions that we really need to focus on patients in ambulatory care, that untreated distress will transform into somatic complaints. Our hypothesis as we move forward that we'll use, the higher the distress, the higher the use of healthcare resources. And we've developed a way at Inova, hopefully in the future, where we can interact with a financial database to look at lab medicine charges, radiology charges, and pharmacy charges, items that might be related to somatic complaints that are more psychological than physiological. And hopefully in the future we can demonstrate that the benefit of interventions actually reduces healthcare utilization or healthcare cost. So just a couple of words about leadership very quickly to come back to this. This is a book, Lincoln on Leadership, that I read about 5 years ago now. And Lincoln made some incredible comments on leadership, focusing on people, developing character, creating endeavors, and effective communication. And one of the things I like best is the first chapter is called Get Out of the Office and Circulate Among the Troops. He spent an inordinate amount of time talking with people that worked not only at the White House, but when he spent a great deal of time in Washington out at Lincoln's Cottage, which was about 3 miles from the White House. And it overlooked, unfortunately, the military cemetery there. So during the Civil War, he spent a lot of time leaving that house and walking over to the cemetery to talk to soldiers as they were coming back from the front. And he always emphasized, you must build strong alliances, persuade rather than coerce, Honesty and integrity are the best policies. Never act out of spite. Getting even just simply doesn't help. And have the courage to handle unjust criticism. And in terms of endeavors, be decisive, lead by being led, be results-oriented. All of these characteristics are extremely important because I think as we search for excellence and try to demonstrate it, I think all of these traits are extremely important. Master the art of public speaking, influence people through conversation, and preach a vision. These are all directly through from Lincoln. So as we begin to conclude, you never conquer the mountain, you conquer yourself, your doubts and your fears. You can minimize those fears by taking on some of the projects that I've talked about. H.L. Mencken, a favorite writer of mine from the Baltimore area, some problems are so difficult they can't be solved in a million years unless someone thinks about them for 5 minutes. Well, we've been thinking about psychosocial oncology and oncology social work for years now, and I think that the answers are there in front of us. And you can accomplish anything in life provided you do not mind who gets the credit. Absolutely a critical statement by Harry Truman. And most importantly, if there's one slide that I would say, don't ever forget this slide. A difference is only a difference if it makes a difference. The end. Thank you.